Hello and welcome. I would like to welcome our guests online and thank you for coming here for our live talk with Dr. Munjed Al Muderis. I'm Tomasz Albrewczyński. I'm orthopedic surgeon here in Pale European Institute, Warsaw, Poland. We are very privileged to see Dr. Munjed now here in our institute. This is very special guest for us because he is the most known in the world surgeon who introduces the osseointegration process for the patients with limb deficiency after amputation and many other problems with limb deficiencies actually. Dr. Munjed did more than 1,500 implants of osseointegration all over the world. Mm-hmm. We just did the patients. We just treat the patients here in Pale Institute with Dr. Munjed, and new patients are waiting for the surgery still in next few days. But today we have this opportunity to speak about osseointegration and hear from the master what's the newest approach for osseointegration and see how you do this. Thank you.
Thank you very much, Tom. Thank you very much for having me here, and I'm more than happy to take any questions, and I'm really honored to be working with a great team of surgeons that are here in Warsaw in Poland, and I'm looking forward to build up the collaboration and the relationship with the team here, as they provide excellent service for their patients, and we are gathering a lot of patients coming from all around the world, basically mainly from the European continent, to come here to have this procedure. Osseointegration surgery, for some of you who do not know what it is a technology that is very innovative. It revolutionized the management and the rehabilitation of amputees and replaced the socket-mounted prosthesis. Socket-mounted prosthesis is the traditional way of rehabilitating amputees, which is a 600-year-old technology which involves a bucket or a case around the residual limb, and it has a lot of problems, including the socket skin interface problems, including mobility and fit, including lack of proprioception. Well, all these problems can be resolved by using osseointegration surgery, which means inserting a high tensile strength titanium implant into the residual bone and connecting it through a small opening in the skin to a prosthetic limb. This technology allows direct skeletal attachment of a prosthesis to the residual body, and with this technology we have opened a big opportunity for people to regain their mobility. It's not a pain relieving surgery, it is a mobility improvement surgery, and it provides patients with a closer mobility to their able body and able limb. So I'm ready to take any questions.
So I have my small help here because I have the questions from the audience here written. Thank you for your introduction, but we already have like more than 20 questions to
Sure.
answer.
Go for it.
So you just explained the advantages for the traditional method, but what are the main patient's qualification criteria for the osseointegration process?
So the indication used to be, in the old days, for osseointegration surgery, only people who are severely struggling with socket-mounted prosthesis, people who were amputees and struggling with their socket-mounted prosthesis. This indication is no longer the case. The indication has expanded much wider. Now I use osseointegration surgery for patients with more complex deformities that cannot be salvaged by limb salvage surgery or deformity correction surgery. Patients who have had so many surgeries and they had enough of their limb because of severe infection, intractable defects that are not salvageable by limb salvage surgery, patients who have vascular disorders, patients who are diabetic, that their limb cannot be salvaged. All of these are options for patients to consider osseointegration surgery. I treat now CRPS patients, and we have very good case series of CRPS patients that have been successfully treated. The latest was a German patient that I treated here in the Paley Institute. We did amputation of both of her legs and cured her of CRPS. Very careful taking of such cases and managing them properly can lead to giving them a new lease on life, basically. And she had osseointegration surgery on one side here in the Paley Institute, and then she came to Australia and had the second side done, and she's recovering back with CRPS cured, which is kind of a very, very new cutting edge technology, and embarking on a new era, because CRPS patients are basically the most difficult to treat, and we all as orthopedic surgeons have at the back of our head a fear of patients with CRPS because it's very difficult to manage. Other indication including patients who cannot wear a socket, such as hip disarticulators, such as very short residuums, such as people who have allergy to socket prosthesis. All of these can be indication. Patients who have knee fusion surgery and they want to improve their mobility, because with knee fusion you get patients that limit their mobility dramatically because they can't go into public transport, they can't get into a car. An amputation can be a solution for them. So it's not only for amputees, but people that may require an amputation in order to improve their mobility. Osseointegration surgery can provide a solution for these patients.
So, on the other hand, do you see any contraindications for the process?
Yeah, so contraindications are divided into absolute contraindications, relative contraindications, and precautions that you need to take extra care with patients that you consider for osseointegration. The absolute contraindication remains are irradiated bone. If the bone is irradiated, especially recently, that bone is dead. So you can't do osseointegration unless you amputate above that level. Patients who are pregnant women, you need to wait for their pregnancy and their delivery to finish, so they are contraindicated. Patients, we still regard young children as contraindication for osseointegration. However, the future is there for potential application for osseointegration for children. We haven't embarked on that yet, but there is a potential win for that. So at the moment is regarded as an absolute contraindication. But the most important contraindication out of all of them is patients who are non-compliant, patients who have high expectations and they will not be compliant with the program and the protocol, and unpredictable patients. So you need to have proper psychological assessment for the patient and need to have a proper understanding by the patient for what they are embarking on. So psychological aspect is the most important absolute contraindication. Other relative contraindications, such as patients who have HbA1c above 7 as severely diabetic patients, patients who have severe cardiomyopathy and cannot cope with the surgery, and patients who are heavily smokers and very poor hygiene. That is a relative contraindications. And then you have precautions when you embark on patients such as vascular disease, diabetics who are controlled, patients who have immune compromise, and patients who are on immune suppression therapy. So you need to be careful with these kind of patients.
Yes, so sometimes just lower the dose of the immunosuppressant patients, or just manage it somehow?
Well, you need to be careful because we've treated several patients. I mean, that category of patient used to be part of the absolute contraindications for patients, but since then we had patients who had osseointegration surgery and then went and got kidney transplant or liver transplant, and they become on immune suppression. You just need to be monitoring them very closely, because it's not about the infection in the leg, it's about if they get an infection and that goes to the transplanted organ, and you don't want to kill that transplanted organ. So you need to have very clear explanation to the patient about what consequences can happen with osseointegration surgery if they develop infection.
Right. You just mentioned about very severe cases like CRPS or like the patients with bilateral problems, with nerve pain. So I just call this osseointegration process because it's not the surgery. You need to have like proper anesthetic assessment, proper setting of everything in the hospital, like the post-op everything. So how you manage it step by step?
So the whole you're quite right. The osseointegration process, you need a multidisciplinary team. You need the pain specialists, you need the psychologist, you need the anesthetists that work with you very closely. It is not a bony surgery. The bony part of the procedure takes 10 minutes. It's soft tissue management, it's proper management of the muscles, the soft tissue, refashioning of the residuum, and it's about how do you manage the nerve endings, because the nerve endings would require RPNI or TMR in order to reduce the chance of rebound phantom limb pain and sensation, as well as to reduce the chance of developing severe neuropathic pain. So, and then you need to follow this patient up afterward very carefully and very closely, because they will continue to have an opening in the stump, which is called the stoma, and this stoma will leak. And it varies from one individual to the other. Some people have more leakage, some people have less leakage. Yeah. This leakage can become smelly, can become pussy, and people freak out and they think that they have an infection. This is not necessarily the case. It's all about how to manage expectations, how to treat these patients, and how to teach them how they look after themselves on the long term, because they will live with this for the rest of their life and they will look at it every day.
So summarizing this, if you want to do the osseointegration, you need to know how to manage the complications and problems.
Absolutely. So this is not like a hip or a knee replacement surgery where you see the patient 1 week, 2 weeks after the surgery, and then 6 weeks, and then 1 year, and then you see them every blue moon. This procedure will require constant monitoring of these patients, and if they come from a remote area, you need to hand them over to people in their local town in order to follow them up. So proper, constant and continuous management and follow-up for these patients is essential.
So I think that's partially explaining the next question asked by the audience, why it's so expensive.
Well, it is not expensive. If you look at the whole package, obviously it's a niche technology and it's at the beginning of its process. Amputation is expensive. And if you look at the LEAP study, have showed that there is no difference between limb salvage and limb sacrifice except with expense. Okay, amputation is expensive. A socket prosthesis in America costs $14,000 every socket. A liner change costs $1,000 to change. People change liners every 6 months and sometimes every year. They change sockets every 2 years. So we have done 2 studies. One was done in the UK and one was done in Australia, shows cost effectiveness, and both studies independently have shown that cost effectiveness, they reach cost neutral at around 5 years. And then anything beyond 5 years, it is cost benefit. So the procedure itself is, the implant itself is expensive. However, the socket is very expensive as well. So when you compare apples with apples, this surgery is not expensive at all. As a matter of fact, after 5 years, you'll be saving money because this procedure will not require changing of sockets, not require changing of liners, and that's if you're looking at it as cost base per what you spend. However, when you look at it from the other aspects, the cost benefits for this procedure where you can get this patient back to the workforce, then you immediately reverse that argument, because a patient returning back to work will become very cost effective immediately. And with osseointegration, they can return back to jobs that they can't do with the socket prosthesis. So there is a clear evidence that this procedure is not expensive on the short and the long run.
Yeah, so you said that the recovery and like the coming back for work is much more quicker and better after this. What's the recovery time? Or how
So,
it's,
if you look
that
at
looks after the surgery?
So if you look at the amputation, amputees normally take 1 year to recover from their amputation. It is expected that more than 50% of amputees take more than a year before they go back to work. And when it comes to bilateral above knee amputees, 95% of them never go back to work if they're doing manual labor. With osseointegration surgery, the technique that I developed, which is single stage surgery, the patients can, depends on their rehabilitation protocol. If they go on fast protocol, they can be loading immediately after the surgery, and they increase the loading by 5 kilos every 2-3 days until they get 50 kilos by 2 weeks. And then they walk with 2 crutches with a trial leg for 6 weeks, then single crutch, and then unaided after. So the recovery time is around 3 months, which is extremely accelerated from the comparable surgical techniques with the other designs and other implants available, and other technology available in the market, such as the Swedish implant with the Opera system, where the rehabilitation time takes up to 18 months. So that's why we decided to make an implant that is amenable to single stage surgery and very fast rehabilitation, in order for that to achieve faster recovery, faster return back to their normality without compromising the outcome. And we have several papers that have published that shows no difference between single stage and 2-stage surgery, no difference between the accelerated rehab and the slow rehab protocol when it comes to complication rates. As a matter of fact, from the studies that I've done on my own patients, when I compare single stage surgery versus 2-stage surgery, the 2-stage surgery has way higher complication rate, but that's in my cohort. But that can be a biased study, because for 2 reasons. Number one is that I started my learning curve with 2-stage surgery, so I did the first 100 cases as 2-stage surgery, and they are the older patients. And with the second reason is that obviously these patients were going through my learning curve, while now I do single stage surgery. I'm much more experienced. And the second reason is that the design of the implant is changed, and the design of the implant is more robust and allow better integration, and compared to the technology that we're using with 2-stage surgery, where we use the German implant, which was chrome cobalt, while now I use titanium implant that is coated with titanium niobium oxide and plasma coating, which is bacterial repellent.
You're right, it's always better to have 1 surgery than 2.
It's always better, because it's less hospitalization, lesser risk, lesser complication.
Every surgery has
patients.
same risk of anesthesia and all the things we are doing besides of surgery.
Absolutely.
Yeah, but we talked about who can have the osseointegration, but the audience, they are asking, is it suitable for athletes, and what you can do after the osseointegration? Every work, or there is any work that you cannot do, or any things that you cannot do?
So in the past, I used to say to patients that when you get osseointegration surgery, you can't do high impact activity. And then I had to treat a lot of British soldiers, a lot of Iraqi soldiers, and American soldiers, and a lot of these people do high impact activity. So despite my advice and discouragement, they went and participated in Paralympics, Invictus Games, and started doing things that they shouldn't be doing. So now we don't recommend any high impact activity for a year, and then after the year they can do whatever they want if they're capable of doing it. And we have several medal holders in Invictus Games, Paralympics, doing athletics with osseointegration surgery, such as rowing, such as speed cycling, such as swimming, and many other activities. And now a lot of the patients do running, do jogging, do higher impact activities, and hasn't shown that these patients had a higher risk of complication than their comparable patients with a socket, or even able-bodied patients. They do, on one note, they do break a lot of components, because because their prosthesis and these prostheses that are designed with regardless of the company that makes them, especially if they are microprocessor knees, they tend to wear much faster because they are designed for socket prostheses, and socket users are not as active as osseointegration patients. So for a prosthesis that it has a warranty of 7 years, we see them lasting only 4 years, and they break more often because these patients are using them much faster, much quicker, and much more impact. It's like a car tire of a Ferrari and a car tire of a Camry. If you drive a Ferrari on the fast lane at 200 kilometers an hour, you wear the tires quicker than you drive a Camry on a slow lane for 40 kilometers an hour.
So you said that based on your experience, your implant changed for more robust, different implant actually.
Yes.
But do the patients, do they need to have a replacement sometime, or
So the implant is designed to stay there forever. We don't have long-term results to show how long the implant lasts. We have several implant breakages of the size 15 of the chrome cobalt implant, which was made by the ESCA company. But with regards to the with regards to the OPL implant, the titanium implant that we designed, to this day, touch wood, we haven't had any breakages. But I don't have the long-term studies to qualify what I'm saying now. So far, we haven't had any breakages. However, we have implant loosening, we have implant failures by mean that fail to osseointegrate. The implant there is like a telegraph pole. If you don't hit it with a car, and if you don't, it doesn't get a fracture, or if you don't rust it, as in getting infection, it should last. However, the external components, they do have warranty time. The dual cone has 2 years warranty. The external components such as the taper sleeve, the bushing, the connectors, they are exposed to wear and tear, and they need replacement frequently. And it's no different to any other prosthetic components in the leg that needs maintenance and replacement on frequent basis.
What's your next goals for improvement for the implants? Any new technologies coming? What do you plan to do with this implant?
So we are working
some new technologies like electronic for this, or some new things.
So there are many aspects that we are improving on. Number one is to get an implant that has more active bacterial repellent. So at the moment we're coating the implant with titanium niobium oxide, which has bacterial repellent capacity, but we want to have more surface coating that would not allow bacteria to live on, such as nanoparticles.
So less loosening.
Less and less bacterial growth. The second is to have active implants that are capable of detecting infection and warning us. So by having smart implants inside, and we're working on technology to develop that by changing the pH of the body, that you can put sensors in the implant that can notify us about what's happening. The third is by having not just active implant, but active defensive implant, where if they get an infection, then they can charge a bactericidal property, such as if the patient get an infection, you provide an ultrasonic impulse on the leg by just using a simple ultrasonic machine that can change the surface coating of the implant and release hydrogen peroxide on the surface from the implant itself by certain type of anodization of the surface. Then allowing the implant to take implantable electrodes and use the smart activation for basically powered limbs, such as in the upper limb where we have implantable devices. In the lower limb we don't have the technology as robust yet, and the technology with gyroscopes is very good enough at the moment, but in the future you never know, this may be the next process to continue with.
So you mentioned about very nice technologies. Can it be used in different medical implants, orthopedic implants like total hips, total knees, or
yes? So all these technologies can be utilized for different implant technology, and especially corneal transplant, hip replacement implants, knee replacement implants, all of these technologies. And with osseointegration surgery for amputees, this provides us with a unique environment where it's a very, very fertile land for investigation and research, because it is the only time where you have a symbiotic reaction between bacterial colonization in the stump and the stoma and an implant that is attached to a bone. So it is a very unique circumstances where there is a lot of room for study and research, and we're working on that.
I'm just asking because I know that you're performing a lot of total joint replacement too.
Yes.
And that's not only osseointegration, but helping patients with arthrosis of the joints.
Yeah. So with complex deformities and with complex joint arthroplasty, I mean, we are planning to do major revision hip replacement in the coming day or two, and this technology may add a lot of potential for patients, especially if they had infected prostheses in the future, and they have revision surgery. With every revision surgery, the risk of infection is increased by folds, and it's always the fear of any arthroplasty surgeon that
it's our
infection is a
nightmare
risk.
every day. Okay, so what's the difference between osseointegration in lower and upper limb?
But as human beings, we walk on legs. We don't walk on four. So what you see, that majority of patients who have osseointegration are transfemoral amputees. There is a massive opportunity, despite that the majority of patients with amputees are below knee amputees. You see more above knee amputees getting osseointegration. And the reason is because it's still a new technology, and still there is a fear about the infection that can happen with osseointegration. People lose more of their limb. However, this is not a valid fear, basically. So we will see in the future that more people will do osseointegration for below the knee, which is comparable to the numbers of patients that get amputated below the knee. However, when you compare it to upper limb amputees, majority of them, they become counter-dexterous with the other limb, because the socket, for two reasons. One is that the socket for upper limb is not very successful, and people usually get frustrated with it and remove it. And second, because of that, basically, the patients tend not to go to their prosthetist. So they move on with their life, and they accept that they are amputees with one arm, and then they don't seek any assistance with prosthetics. Mm-hmm. And third, added to that, is that there are a lot less upper limb amputees than lower limb amputees. So that's why osseointegration surgery has not been done more for upper limb. I've done only 25 upper limb osseointegration surgeries, and that is again one of the largest case series in the world, despite that we've done over 1,500 lower limb osseointegration surgery for lower limb amputees.
So I know you perform up to 200 per year, this kind of surgeries. The question is how many you already did here in Poland, in the institute. What is your plan? Because I know we are waiting for the patients. We not only performing the osseointegration, but RPNI and the nerve surgeries, and also revisions like tomorrow. What's your goal?
So as purely osseointegration surgery, we've done around 1,500. But when it comes to RPNI and TMR, we've done over 3,000 so far. Mm-hmm. So it's much larger number when it comes to nerve management, because a lot of patients do have phantom pain, neuropathic pain, and have a lot of suffering with pain issues. And there are two separate matters. One is the mobility, which can be improved by osseointegration, and the second is pain management, which can be helped by nerve surgery. My hope, I mean, we've done a handful of cases here in the Paley Institute, but my plan is that this will become a regular event, and we would attract, with the help of people referring patients to us, that we would attract more patients coming and helping more with osseointegration surgery. And I would hope that every visit we would come and do 10 or 20 cases, if that's possible, and we would do them at in a shuttle kind of frequency, where we come 3-4 times a year to do these surgeries and attract patients from all around Europe to the Paley Institute, and we will welcome people to come and learn how this technology is
Thank
done.
you for this, because it's not only the surgery from my perspective, it's many hours of learning and tons of knowledge giving to us also, because we need to follow this patient, we need to see these patients. As you mentioned, that you need the team, you need all the steps for the process, so it's well built here by you. So thank you for doing this and making this more achievable for the patients for Europe and this side of globe. Actually.
Thank you very much. Yeah.
Are there more questions from the audience?
Yeah, the last one.
The last one? Oh. Very quick one now.
Mm-hmm.
Can they swim with the
Yes,
prosthetic?
so what we recommend, patients, when they have the surgery, day 3, I let them have shower and wash the leg, and then by 6 weeks they can go and jump in the ocean and swim in the sea. Salt water is advisable as early as 6 weeks. River water and lake water and public swimming pools that are not salted, that chlorinated, we advise them to wait for a year. But they can swim. I have a lot of patients. My first patient, actually, he was the flag bearer of the Australian Paralympics in the Sydney Olympics in 2000, in year 2000, and he's now the main coach for. He's a professor of biomedical engineering, but he coached the Paralympic team, and he swim in a public swimming pool every day in the morning. So I have, as you may know, Australians are very fond of swimming, and we have a lot of Paralympian swimmers that have had osseointegration surgery, basically. So swimming is very important.
Yeah, so 2 more questions.
Yeah, go for it.
Would this type of technology reduce the risk for someone who had a post-op infection following a large revision on their stump that is being denied OI currently, locally due to infection risk?
Yes, I mean, this is a philosophical argument between systems and the fight of the titans, if you call it. The technology that I've developed allows several patients to have revision surgery. I've treated patients who had failed opera systems. I've treated patients who have failed OPL system, and usually we take the implant out, we put an antibiotic spacer, wait 3 months, and then come back and implant them again. And these patients do very well. I've done several patients in the UK with the same. As a matter of fact, the NHS have approved the cohort of 18 patients who have failed opera system from the previous study, and all these patients that have been reimplanted with OPL system, basically. I don't see any reason why any failed implant, whether it's an opera, ILP, OPL, ESCA, failed hip replacement, failed knee replacement, due to infection, there is no contraindication of doing osseointegration surgery on them, as long as you eradicate the infection, you treat it very well. The last patients that we did here was an infected patient, and we cured the infection, reimplanted him, and he did very well.
Additionally, he has also the stump deformity, so we had to treat the deformity and infection, and then the osseointegration.
Yes,
so many things.
So it was a combination of deformity correction, treatment of the infection, as
Correct.
well as osseointegration surgery, which worked very well.
And he's doing very good, so
Yeah.
he's happy. The next few questions about the accessible for this process. Why is still not very popular around the world?
That is a very, very political question. And so the first time I gave a talk in front of an audience about osseointegration surgery, and in the audience there were a group of people. There were surgeons, there were rehab physicians, there were prosthetists, physiotherapists, and other clinicians. And the first question that I was asked by the prosthetist is that, are you here to take our jobs away from us? You need to understand that this technology is like the introduction of the digital camera and getting rid of the film development.
Mm-hmm.
So you're replacing a technology with another technology, and there is always a fear about losing the business, because prosthetists earn their living by doing sockets. What they don't understand is that by taking the socket away, that doesn't mean that they will lose the job. They're replacing that by changing components and improving on the patient mobility. However, there is still a massive resistance to adopting this by many prosthetists, because the fear is that if these patients get osseointegration surgery, then there will be no more sockets, so that's loss of business. So that's one factor. That doesn't mean it's everything, but also the fear about infection. Infection is around 34% superficial infection, majority of it is manageable. Deep infection happens in 5%, and that requires surgical intervention or intravenous antibiotics. So majority of the infection that occurs is manageable without requiring revision of the implant, without requiring higher level of amputation. But it's still a factor that plays a major role in the fear of expanding this procedure. This is no different to the introduction of joint replacement. In the 60s, Sir Charlie was laughed at when he developed the hip replacement surgery. And then look at it now, hip replacement is everywhere. Dental implant had the same problem. In the 90s, dental implant was a new thing, and people were so scared of it. I have a dental implant here, which is osseointegration, and the mouth is the dirtiest part of our body. And
worse than your leg and your arm.
Yeah, and so it's much cleaner to have an implant in the leg that is exposed than a dental implant. And you can see now it's widely acceptable. I'm very certain that osseointegration surgery for amputees will be the norm in 10 or 20 years. But things can be taken slower pace when it comes to high level of resistance from other industries that do not want it to be successful. And it's no different to the petrol car, electric car industry.
Yeah, yeah, you're right. We're getting more and more questions about these infections and osseointegrations, because many patients, as we both know, that your implant is not only in the market.
Yes.
And many surgeons, they performing some osseointegration.
Yes.
And for them, the main contraindication is infection, ongoing or just lately finished infection around the stump. And we have more the patients that they are cancelled because of this. If you can explain them one more time that this is not contraindication, we can treat it actually and do the osseointegration.
So we're talking about infection in the osseointegration, or
no,
infection
of the stump.
So I have big cohort of the patients that I've treated, over 100 patients. I did osseointegration due to infection. Whether it's a knee replacement that got infected, whether it's a stump that got infected, whether it's a foot and ankle that got infected. And all you need to do is that you can stage it. You can put antibiotic spacer. You can, as long as you achieve cure of the infection, you can osseointegrate it. There is no different to doing revision knee replacement or revision hip replacement surgery on an infected hip. It's not any different by any means. You just apply the same principles, you apply the same guidance by proper debridement, washing it, eradication of infection, and then coming back on a healthy tissue, osseointegrate. It does work, and there is no harm from doing that at any stage.
Okay. I don't see more questions. I just see great things, and I'm becoming jealous about this because we've got many thanks and great things. So, Magda?
Two more.
Two more, yes. You can ask because I don't have them.
What are the options for replacing the implant?
Yes, so replacing the implant, the way I designed the implant as well. So the implant design is, it's curved implant. It is matching the bone.
Mm-hmm.
That's for the femur, for the tibia is straight. It has rotational stability, which fins. It has osseointegration property in the distal 8 centimeters with with high porosity. It has axial stability with a collar. But the implant also is designed to take a hip replacement and is designed to take a knee replacement on top of it, and is designed to be removed. So replacing the implant can be done well. So if you have an intractable infection that you can't control, but the implant is solid, I would debride the bone around it, and you don't need to replace the implant, and you can cure the infection or suppress the infection. If you have a loose implant due to infection, then that problem solves itself out. You take the implant out if it's loose, and you can replace it with antibiotic spacer. If you have a rigid implant that is well integrated and intractable infection, and the infection is higher up and you can't debride the bone, then you can do an episiotomy in the implant, and we have coring device that is specially designed for this implant. You core around it and you keep the bone and you preserve the bone. You do not need to amputate above the level of the implant. I repeat, you do not need to amputate above the implant. I have not had to do that to this date. Majority of the cases can be salvaged, and you can keep the bone and salvage the bone without sacrificing it. You can put an antibiotic spacer, and you can come back 3 months later, put a new implant in. So it is replaceable.
We've got a patient who had a low dose of radiation to prevent arthrofibrosis.
Ooh, that's
which
unfortunate.
Wasn't working.
Yes.
Of course. But does he can have osseointegration?
What we need to do, we need to identify if the bone has blood supply, and that can be done.
Alive?
Yeah,
Still alive?
that can be done by two things, and ideally. You should have non-invasive technique by doing bone scan and see if the bone is shows any increased vascularity in the area. You can do an MRI scan as well, and you can do a PET scan. And the second approach is by exploratory surgery, by going in and take a sample from the bone and see if it's viable, and then you can proceed with the procedure safely.
Yeah.
Basically, if there is a level of the bone that is irradiated, that level can be resected, and if it's, let's say, in the distal part, that distal part can be resected. If it's in the middle, you can segmentally resect it and put it back together. And if it's in the proximal part, the same thing can happen.
Yeah.
So there is a solution. There is always a solution.
Okay. I think we answered all the questions. You are very welcome to comment under our live, and please comment it and ask more questions. We are very happy to answer them. The time is over, unfortunately. Thank you, Dr. Munjed.
No, thank you very much.
That was my pleasure to see you here and hear this all information.
We can do it again. Pleasure is mine. Thank you. Thanks very much.